We are delighted to bring to you again a legend in dementia training, Dr. Tam Cummings. Dr. Tam, as she is known in the dementia community, is a practicing gerontologist who has devoted her professional career to educating both professionals. In 2009, she founded the Dementia Association with the mission to inspire, educate, and empower dementia caregivers. At Anthem, we utilize her transformative work, including the Itty Bitty Dementia book, in our daily conversations with families of those with dementia. If you have not received your copy of the Itty Bitty Dementia book, you can pick one up at your nearest Anthem community. Families, professionals, and caregivers, it is an honor to once again present to you Dr. Tam.
Thank you, Chris. Thank you, Jamie. Thank you, Anthem Memory Care. It is always so much fun to talk with you guys, and the efforts that y'all are making to educate the families that you do care for, as well as your staff. It's heartwarming, and it's wonderful, and it makes me feel like the world is a better, safer place. So thank you guys for what you do. As we talked about just before we turned on the recording, this session is going to have a lot of slides that you're somewhat familiar with. You've seen them in the previous settings, and remember, each webinar builds on the previous webinar just because of how complex the dementia diseases are. And this one, you're going to see a lot of those old slides because now we're really going to pull together what communication in dementia means for you, what it means for us as caregivers, what it means for your loved one who has dementia. So just to get started, you have to remember that communication is difficult, it's strange, it's odd, because you have to balance the person that you knew. You have to balance which language they're in. So Chris, if a person spoke 3 languages, they'll lose their third language first, then their second language, then they'll be back to their first primary language, the language that they learned at home. And so that is something for families to be aware of. Your loved one, if they originally spoke German, will go back to German. Spanish, they'll go back to Spanish. Japanese, they'll go back to Japanese. And so having a family member who speaks that native language is very, very critical. But you also have to remember that communication is not just language, because your loved one is losing the ability to understand and respond to language or sounds, to noise, or to speech. And it's for a number of different reasons. So when we talk about communication in dementia, we don't mean just saying good morning, how are you? We're also talking about recognizing the communication that the person is trying to give us through physical actions, through behaviors, through the response that they have to the approach from you or another caregiver. And so remember, you have those dementia behaviors. Hallucinations are giving you information. A lot of times hallucinations may be identifying the dementia. Lewy body has those 4 hallucinations. They see children, bug spiders, rats, and snakes, bad people coming to get them, or their spouse or caregiver having sex. Hallucinations could also be an indicator that your person has the onset of an infection that has become delirium. So a urinary tract infection quickly becomes delirium in a person with dementia, and hallucinations are telling you this person is sick, especially if this is a behavior you're not accustomed to seeing. Scatological behaviors involving urine and feces, can also give us an indicator. Now, as caregivers, if we're not paying attention, people do unique things. There's unique human behaviors that occur when a person needs to go to the bathroom. And that can include holding one's groin, one's private area. For men, it might be going over to a tree in the community. It might be finding a trash can. Someone might defecate and urinate in their bathroom sink. That's confusing the sink for an outhouse. And you have to remember, this generation didn't necessarily grow up with indoor plumbing. Your person may have delusional behavior. And delusional behavior is when a person has beliefs that are not real. Now, in most of the dementias, accusing the family member of stealing from them, that is a delusion, that is a belief that's not real, occurs in stage 5. But in Lewy body dementia and in Parkinson's disease dementia, that delusion behavior is a communication that we see in stage 3, very, very early in the disease. And for those families, that may actually be one of their first clues that there is something cognitively wrong with their loved one, because you're suddenly being accused of taking the bank, taking the house, taking the keys, taking the car, taking stuff away from them, or stealing stuff from them and misplacing it. So it's not just a behavior, it's also a communication about the fact that this is brain disease. And if it's Lewy body or Parkinson's, much earlier in the disease, but later on in stage 5 of the disease, a behavior that we expect to see. And for the family, you may not realize this is normal communication because the human brain doesn't know it's sick. I can't find it. Chris is here. He looks suspicious. I bet he's the one who's taken my stuff. And so you see that type of behavior. And what they're communicating to you is they're lost. They're lost in their home. They're lost. They're not safe to drive. It means that there is significant brain damage, a lack of empathy, or a lack of speech entirely. First, we tend to see this loss of empathy as a communication method. And in that, I mean that there is no emotion left on the face. The face is very flat. The voice and the pitch of the voice stay very, very flat. Or there may be the total loss of speech. There are also, in the frontal temporal dementias, the way the person begins to use or stop using speech, the way they communicate with you, is actually a sign of the type of FTD that they have. So, for example, semantic variant primary progressive aphasia of the frontal temporal dementias is a dementia where the person's communication impairs them from being able to use nouns. So instead of saying, I want to pet the cat, they may describe that fuzzy, soft, purry thing. And you notice that this person begins to use a lot of different words in an attempt to communicate, and understand eventually that communication will become, for all, well, most people with dementia will lose the ability to use language at all. So very early on, you may begin to see these features of the disease. They can have verbally or physically aggressive behaviors. Now, those can be part of dementia, or it is the person without the ability to tell us that they're having pain issues, anxiety issues, or depression issues. So things that you may not have thought of as being communication, to me, are very clearly communications from this person who cannot articulate to me they hurt, that they're actually suffering from acute pain. Or physically and verbally aggressive can also mean that delirium has started and is a side effect of the urinary tract infection. We can begin to see sexual behaviors. Now, this can get people really excited, but some of those sexual behaviors indicate to us it's Lewy bodies. They're the ones with the hallucination that their spouse is having sex everywhere. But other sexual behaviors can be that the person doesn't recognize their daughter, and so now they think their daughter is their wife because of how their brain is declining. And so they're going back into old long-term memory, and if the daughter looks like the wife and the father now thinks he's 30 years old, then it makes him that he must be married to this woman. So you can see behaviors sexually where the person may not be aware that they're in a public place, that they're in the living room of the community. And so they may begin to touch someone or to touch themselves. And those are things that are just simply communicating a change in vision and an inability to recognize where I actually am. So it's nothing we're going to be upset about, and it's nothing you should be upset about. You don't need to be embarrassed about it. Humans are humans, and we have sexual behaviors. It's just that in dementia, it's also a communication technique that we're figuring out. Falls are a communicator to us that the brain is very declined, the brain is continuing to die, that there is massive damage in the motor cortex, the premotor cortex. And if you'll go back and look at your very first session with Anthem, you'll find that falls are also a clue to the type of dementia that a person has. Urinary tract infections cause communication in a totally different way. The person is either very lethargic, and difficult to rouse, difficult to awaken. And this is much different. This is a change that occurs in only a few hours, that a urinary tract infection can set off that type of a reaction in a person with dementia as the infection begins to cause delirium. So hypodelirium, very lethargic presentation, difficult to get them to speak to you, and 2 hours ago they could speak to you, or a very agitated physical and verbal presentation, which is called hyperdelirium, or a combination of the two. And these go hand in hand with urinary tract infections or with any infection that your loved one might have, because the brain is damaged and it cannot protect itself or the body from having infections. ADL challenges, these become very challenging for us as caregivers, because your person is challenged with care, not because they're trying to make our jobs more difficult. They're challenged in care because they're not understanding the words that we're saying because of brain damage. We may be moving too fast. ADL care, a lot of the ADLs are intimate care, bathing, dressing, toileting, grooming. Those are intimate care things that we're doing. And because the person's brain is so declined, we can have real challenges with them because they don't understand what we're doing. We may have a male who only wants a male to attend him. If a female attends him, he becomes very agitated, or vice versa. Those are very common things, but they're the person trying to communicate to us that whatever it is that we're doing, they don't understand, we're scaring them, or there's modesty issues and they're having challenges with that. Pain, anxiety, and depression behaviors. Remember, these are not only the behaviors that you see, but this is your loved one trying to communicate to you, I'm in pain, or I'm having acute anxiety, or my depression is not treated. And you have to remember that people with dementia need an antidepressant as part of the disease treatment. And most people with dementia also need an anxiety medication that is a routine anxiety medicine, meaning it's given every day. And they also need routine pain medication for chronic pain that comes from living decades. If you're in your 60s, you're in your seventh decade of life. If you're in your 70s, you're in your eighth decade, your 80s, your ninth decade, your 90s, you're in your 10th decade of life. And so there is pain there. But the communication may not be, oh, Chris, my back is hurting. The communication may be that I'm rocking, that I'm physically or verbally aggressive. But now I've got to go back and figure out, is that communication coming from a dementia behavior? Is that communication coming from an infection behavior? Is that communication pain, anxiety, or depression? Sleep changes can be part of dementia communication, that the disease is advanced and the person is sleeping more and more now. Or it can be a sign of somebody in pain, having anxiety, or having depression. Changes in appetite, sighing, moaning, kicking, grimacing, punching, slapping, again, verbal or physical behaviors are clues to us that the body, and by the behaviors of the body, we're getting communication clues to go check these things on that person with dementia. And then other things are things like grinding teeth, blinking rapidly. A lot of people don't understand blinking rapidly is a sign of untreated pain. Picking at the skin, screaming and biting or punching the caregivers. And these are all things that are done by people with significant brain damage, people usually in stage 6 or stage 7, because they don't understand what we're doing. What we're doing can be hurting them. If your arthritis is bad enough, changing your clothes and bathing you can cause you pain. And so because of that, you might very well react. So our response is that this person is not mean and nasty and bad. This person is communicating with us. We have the 3-pound brain. We have to figure out what it is they're trying to communicate. And is it a medicine we're missing? Is it a behavior we're missing? A nausea is the inability of a person with dementia to recognize that their brain is damaged. A damaged brain simply doesn't realize it's damaged. So the more you tell a person with dementia they're doing something wrong, the more agitated and angry you make that person. And the more agitated and angry you make them, the more combative, aggressive they become because you're annoying them, yet their brain doesn't understand what it is that you're doing this. So to the person with dementia, it appears, Chris, that you're just doing this to be annoying to them. And the reality is, if I begin to tell you, Chris, right now that I see issues with your cognition, your human universal response is to become furious. So a family caregiver may think that person with dementia is mad at me because they're in denial. They're not in denial. The brain doesn't recognize it's doing anything wrong. And it wouldn't be, if you think about it, Chris, it wouldn't be a whole lot of fun for me to follow you around all day long telling you every single thing you're doing wrong. As you go through this, you have to remember that the person you love is no longer the person that you knew. They are becoming the shell of who they were. And so post-death grief starts. And because of your grieving, you may find out that you're treating your loved one differently and that you're not getting the communication that they're trying to get to you, either through their behaviors or through the type of dementia that they have. And so because of that, you may continue to try to force them to have short-term memory. What did we talk about this morning? Don't you remember we went to dinner last night? Instead of recognizing that because of brain damage, the short-term memory is lost, but I can still communicate, Chris, if I respect the person's brain and I go back in time to where they actually are now. And even though this person may not recognize me as their daughter anymore, they still understand my tone and pitch of voice. They still know their first name. They still respond to you and I being pleasant and happy. And the hard part, Chris, I think, is when you have to amplify your voice and get closer to a person, that you don't get so close to them and change your facial construct to where you look like you're actually screaming at them. And somebody in my face screaming at me, Chris, is somebody fixing to hurt me. Therefore, because of dementia, I'll communicate back with a fist that I don't want you to do that anymore. So there's all kinds of communication going on, and it can be hard to realize this is still my mom, but now she's very, very ill. And if you go back and look at pictures over the last 10 years of your loved one, blow them up to where it's just their face on the screen, snap a picture of that. Those pictures will line up together at the end of your file. Chris, you can look and see where over the last 10 years, there has been a steady change in how your loved one looks and also how they communicate. And I really want to stress this part to you because I met a family last week that came in and told me her husband was in stage 5 of the disease. And it was very clear after speaking to him that he could not put a string of words together into a coherent sentence. It was evident in speaking to him that he was responding to my pitch and tone of voice, not to the words that I was saying. And that he wasn't in stage 5 at all. He was actually in stage 6, but because it was her husband and because she loved him, she felt like he still communicated with her, and he wasn't. It was what she wanted to see. So go back as hard as it is and look at those pictures and realize that you see the illness in their eyes. You see a blankness. That picture where you thought they were smiling, you realize when you look closer, you're the person smiling in the picture, but they're not. And then there can be things where not only do they accuse you of stealing from them, but they also do this social laughter. And social laughter, Chris, is something you and I do when we're lost in the conversation. We zoned out for a minute at work and realized everybody else is talking about something else now. And so we sort of, ha, 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 ha. Well, families can interpret that social laughter as meaning this person understands what's happening around them, and they can miss that social laughter is actually the person confused about what is going on right now. So, Chris, this is the best information I can give you. Stop arguing with your loved one. We don't argue with people with dementia. We don't tell them, no, they're wrong. This is how they do it. We go with where they are. We move with their flow. But Chris, human instinct is to correct a person. And if you're a parent, you've been correcting little people since they were little people. So you have to stop arguing, stop correcting, Stop teaching. These are not teaching moments. This is a dying brain. Be accommodating. Sometimes you need to just stop talking. You're just talking too much. When we move a loved one into memory care, we don't have long conversations with them about we're moving you to memory care. They don't have the brain capacity to understand this is a medical need and a medical move to a medical social model because we know that works best. Stop trying to reason with them. There's three people you cannot reason with. Teenagers, you can't reason with them because their brain is still developing. Drunk people, you can't reason with a person who's alcohol impaired because their brain's full of alcohol, and you can't reason with somebody with brain damage. And that's what your loved one has, is brain damage. And chances are, if you're on this webinar, it is significant brain damage. And we know this because all the research says you don't look for help or outside assistance until you reach stage 5 of the disease. And in stage 5, at the very beginning, a half a pound of brain tissue is already missing, even though this person doesn't look sick. So just stop arguing. If they want to know where their car is, it's getting the tires rotated. It's getting the oil changed. If they want to know where grandma is, grandma's where grandma was. She's out gardening. She's gone to the garden club today. She's at the quilting club. She's off doing shopping. She'll be along later. Their brain's not able to hold the memory, so stop trying to correct them. Stop trying to teach them. Chris, I think this would be a beautiful t-shirt.
I agree.
So in communication in dementia, you have to understand words don't mean the same thing because words don't sound the same. The word that you think you're clearly saying is bath, but I may be hearing balls and think you mean we're going to go outside and do something with a basketball. Language changes because of brain damage and because the brain is dying in the reverse manner from which you learned. That's why the person loses additional languages and comes back to their primary language. And the way that you and I respond to that, approach them or assist them, is everything about the communication. If I move too quickly, I scare them. If I'm not down in their visual field, they don't see me at all. And people with dementia can have an object right in front of them and cannot see it. So when I communicate, my voice is animated. I'm happy. We tell you in memory care, leave your unhappiness at the door because you can't bring it into our community because the residents will pick up on it. So my tone is happy. I'm very complimentary, and I make certain in a community that I constantly compliment people. And if I'm doing actual ADL care with that person, I'm using their name over and over and over again, their first name, because that's the name they know most. And every step of the way, I'm congratulating them and telling them they're doing a great job. The same thing I would do if I was dressing a 2-year-old or a 3-year-old. I would talk to them the whole time. So in communicating with dementia, it doesn't mean I'm going to keep telling my mother I'm her daughter. Because if my mother doesn't remember me, all I'm doing is upsetting her and making her think they've let a crazy lady in. But if I leave the daughter part out and just have the visit, then the communication worked really, really well today. Is that making sense, Chris?
It does make sense.
Okay. Things we can do and things we cannot do. Their reality is your reality. If my mother thinks it's 1970, it's 1970. I'm only 10 years old. I'm obviously not 10 years old. Therefore, my mother thinks I'm her mother. And that makes sense to her, so that's fine with me. We are not lying to people. If I tell Chris or Jamie or another adult with a full brain something that's not correct, I am lying to them. But these people have brain damage. And if I told them reality, it would scare them. And why in the world would I want to do that? So we use empathy. If they're looking for somebody dead, we respond to the empathy of they're missing that person and this is emotional and they need emotional support right now. They do not need to know that person died. Don't you remember it? And always the brain runs the body. And as the brain becomes more and more damaged, the body works less and less efficiently. The things that we can't do, and this is where you have to teach your family, and some of you are going to have to put on your parenting voice. You cannot quiz people with dementia. All you do is annoy them, embarrass them, agitate them, and end up making them angry with you. And why would you want to do that? We don't go up to people with COPD and demand they blow up balloons. We don't go up to people with amputated legs and demand they run down the hallway. Your person has brain damage. The correct approach is from the front. I make sure I'm in their visual field, I'm in their eyesight, right in front of their eyes. And then, how are you? My name is Tam. I'm here today to do this. And I'm ready to repeat it, and make sure I'm keeping my sentences short and make sure that I'm watching for any type of comprehension from the person. And if I'm being pleasant, at least I should get a smile back. And that's much different than tell me who I am, said in an angry and demanding voice. Now, these are the lobes of the brain, and you remember the left side runs the right part of your body, the right side runs the left part of your body. Each one of these lobes causes different changes in communication for your loved one. And remember, it starts with hippocampus, and hippocampus is Greek for seahorse because it really does look like a little seahorse, but this is what allows you to make memory. And once this becomes damaged, Chris, it doesn't matter how many times you tell me what I had for breakfast or that I just ate breakfast, my brain doesn't register it or remember it. So I'm going to tell you I want more food, or I'm going to tell you that whatever you're telling me is not real. Now, Alzheimer's starts right below the M and the P in the picture. That's where Alzheimer's starts. It's a cortical dementia. It begins on the outer part of the brain, but then it moves into the limbic system, into that green area that is the hippocampus, and it destroys it. And once Alzheimer's is present, the communication behavior you see from your loved one is a constant repetition of questions and asking the same thing over and over again, or doing the same behavior over and over again. And that tells you not that they're trying to annoy you, that tells you that their hippocampus is damaged, and you now have to change how you speak with your loved one because they can't change what's happening to them. The frontal lobes are the lobes that we're most likely to fuss at our loved one about. These are the lobes that control who I am. This holds my family, my education, family memory is in there, facial memory is in there, speech, rational thought, impulse control, judgment. Impulse control means that if I think it, I say it. And that's why some people get very upset with their loved one, is their loved one tells them exactly what they're thinking, and it can be hurtful. I've known people that were great caregivers but cannot do dementia care because they didn't understand that, yes, this person's communicating with you, but the communication is offensive or it's hurtful, but it's not purposeful, it's brain damage. And that's what is most important for you to remember. The temporal lobes are hearing, language, smell, facial recognition. Again, this is usually family facial recognition, smell, and different types of memory. But this side is formal language. And you and I always think of formal language as being how we communicate. This side is singing and cussing. You and I also communicate by singing and by cussing. And in the case of dementia, formal language dies first. So if your loved one's communication is through curse words, but they can still sing all 4 verses of Amazing Grace, that doesn't mean God's forsaken them. It means the left side dies first, and it leaves what's on the right side, which is singing and cursing. And we can communicate a lot through singing. We can also communicate a lot through cursing. It's just that we don't take it personally. You don't need to take it personally. And it's odd, right before this started, a gentleman called me, and his wife had passed a few weeks ago, and he found my number and he called me. And he said one of the things that was most upsetting to him was his wife suddenly began to use the F word to him, and she'd never done that before, and he was so offended by it. And now he understood that it was actually a sign of the progression of the disease, and it was not the memory of his wife he needed to hold on to. It was simply part of the disease. Does that make sense, Chris?
It does.
The occipital lobes translate what you and I are seeing. It's what allows you to walk or drive or move around objects. It gives you depth perception. Glasses simply bring things into focus so that when they go to my occipital lobe, they're in focus. And it's another thing of facial recognition. So the three lobes that hold facial recognition are all heavily damaged in the course of this disease. And that's why my mother thinks I'm her mother. That's why she thinks my father is her grandfather. It's not purposeful. It's the three areas of the brain that hold facial pictures are damaged. And so she's looking for people that don't exist anymore. It's communication. You just may not have realized that that was communication that you were witnessing. Sorry, my clicker moved. The parietal lobes are pain, touch, taste, and temperature. And you need to know these because people in pain have a whole bunch of behaviors, so much that we even have a pain assessment in advanced dementia scale. Touch remains till the end of life. They remain very tactile. Body temperature begins to change. And so when people are colder, they tend to isolate. They want to go to their room and sleep because in the room they know there's a bed to get into with a cover over it. They may pull themselves in tightly, trying to cover their hands. They may cover their hands between their legs. They may rock. They may do all sorts of things. But Chris, if I touch a person with dementia's hands and their hands are ice cold, even if they tell me they're not cold, they're still cold. What I'm making the assumption of, and what I believe to be true, is that the reason they told me they're not cold is they didn't understand the words that I just said, are you cold? But if their hands are cold, they're cold. And then I know their body temperature is dropping. It's not the same as you and I. In taste, a person with dementia begins to taste and crave sweet things. So the communication can be that, Chris, you make me a steak. It's my favorite steak. You bring it to me. You serve it to me. And because it doesn't have a sweetness to it, you didn't put a sugar rub on it. You didn't give me A1 steak sauce. You didn't give me ketchup. You didn't give me something, barbecue sauce. You didn't do something to make it sweet. My communication back to you is you don't know how to cook. You're trying to kill me. This is terrible food. But if you had done any of those other things that made it sweeter, I'm able to eat the meat a little bit longer because it's got a sweetness to it. But the communication back to you or the family member may be that this food is terrible, this food is awful, and by the way, I've got frontal lobe damage, so let me tell you how bad you look today. But it's all communication coming back to brain damage that says this thing you cooked for me doesn't taste sweet to me, therefore it must not be good food. Did that make sense?
It does.
Okay, yay. Now you got to remember, think of every memory as being a file. And I'm in Ohio tonight. I'm speaking at your Cincinnati community tomorrow with Amanda. I'm very, very excited about it. So when you think of every memory as being a file, how many files do you have for driving in Ohio? Snow, ice, rain, sleet. Y'all have terrible weather up here. I don't know why you guys live up here. We have warm weather in the further south of here. But think about how many files y'all have for driving versus someone from New York City who's never even been in the front of a car. Okay. And then think about how complex the files are, because family members will say, well, how come they knew banana this moment, but not the next moment? And that goes back to how complex your brain actually is. Are you eating a banana? Are you going bananas? Bananas are one of the first foods we got to eat. When I was a kid, I realized monkeys like bananas. Then there was a TV show called The Monkeys. They acted bananas. Now I know that banana means crazy. A person can have something colored banana yellow. Some of you are very wealthy, grew up with a banana bicycle seat. You can make a banana cake, make banana pudding, make banana bread. You can fry bananas. You can fry bananas, put rum on them, and then serve them with ice cream and call it Bananas Foster. There is a food called the Banana Splits, a cartoon called the Banana Splits. There is a band called the Banana Splits. And bananas are also used to teach boys how to use condoms. Now you've got a sexual banana that you didn't even know you were going to have today. So it's not one file on banana. So even though the brain damage has now destroyed part of my banana files, Chris, I got a whole bunch of other banana files over here, And that's why I may suddenly use that word, that term, that thing that everybody thought was gone from my brain. I can suddenly communicate with it. And families think, well, that must prove they're faking it. They're not faking it. You're witnessing brain damage and a connection to an area of the brain that didn't exist before and may not exist again. And if banana is that complex, if a fruit is that complex, how complex is the file for the word mother? So the ladies listening are mothers. We all had a mother. You have daughters who are mothers, cousins who are mothers, sisters who are mothers, aunts who are mothers, great aunts who were mothers. If you're Catholic, you have a whole other set of mothers that come under a religious file, but also under a Mother Mary file. Yeah, mother can be used as a curse word. Mother can be used as a sexy word. She's a hot mama. Mother can be used as a derogatory word. She's a hoochie mama. So it's not that you have one file, Chris, on your mother. You have files on your mother as you grew up. You have files on what your mother did for you when you were ill. You have files on your mother at your graduation, at your prom, at your wedding, when you went to college, when you finally moved out of her house. You have files on your mother when you gave her her first grandchild. So it's not one file on this very important person in our lives. It's multiple files. It's not even, I couldn't even give you the guesstimate of the number of files that include the word mother. And so a person is trying to communicate with you. It's just that their files are messed up, but it doesn't mean that at some point later in the disease, there can be a moment in time where a file connects that still holds the correct information. And for that moment, for that second, the person is actually reconnected to you again, and then the connection is gone. Does that make sense?
It does make sense.
Okay, so remember your file cabinet. Every memory is a file. The brain is the file cabinet. It started at birth. We went with mom and dad, please and thank you. We went off to school. We joined the military, college, got a job. We got married, had kids, grandkids, great grandkids, and then dementia begins, and your loved one begins to lose their memory in the reverse manner. So if my mother now thinks it's 1970, that means she's a 30-year-old woman with 5 small children. I can't talk to her about being a great grandmother or a grandmother. I'm simply going to alarm her and make her very concerned about me. I must be crazy. She's a 30-year-old woman with children. And as the disease continues, she doesn't remember having children. So now my conversation with her is going to be limited to that time period of her life, from a teenager back to when she was born. And then finally, people with dementia want to go home. And the home that they mean is not a physical structural building. It's these 7 things right here. These are the things we ask you to do to make that apartment at Anthem feel like home. These are the things that make home home, not 5 bedrooms and 5 bathrooms. It's your pillow, the type of pillow you sleep on, the type, color, fabric, and texture of sheets that you use, your weight and the texture and feel of your bed covers, your favorite chair, your art. That's very important to telling you your home. And family photos. And Chris, if my mother is far enough back in time, I don't have pictures of her 24 great grandchildren on the walls. I have pictures of her as a young girl with her cousins, maybe her twin sisters once they came along. I have pictures of her parents and her grandparents, because those are the memories, those are the family photos still in her brain. And then the last thing that makes a home home is the smell. And we don't know that smell, but you know your loved one's favorite perfume or cologne. And during the day, we spritz that on the lamp. We turn the lamp in their room on, and their room takes on an odor that we know they love. But it's these things that make that apartment home. It's not a big fancy thing. It's these very simple things. It's the things that when you crawl into bed at night, you go, ah, because you're home. So as you look at your loved one and you think about how they're behaving or how they're acting, you have to remember the brain is moving in a backwards fashion. Which one is the real TV? You have to remember which one is the real which one is the real phone, because the little iPhone came out in 2007. I grew up with the phone on the wall in the kitchen, but it had a rotary dial, not a push button dial. But my mother actually grew up with a candlestick phone. And so people had different phones, and that candlestick phone doesn't look anything like my iPhone. Same thing about clothes washing. We didn't have indoor plumbing across the U.S. until 1972. My mother didn't have indoor plumbing in her house until she was a senior in high school. So for my mother, that's how you wash clothes, not the washing machine on the bottom. And for my mother, the outhouse and a number 5 wash tub is how she grew up bathing and going to the bathroom. So trying to get her now into a modern bathroom, she's not quite sure what she's supposed to do in there because she didn't have that in her house growing up. Now, puddles and potholes, I want you to remember, because people with dementia don't respond well to anesthesia, and their communication will usually take a sharp decline after anesthetic surgery. And the reason is for puddles and potholes. If you think about a street full of potholes, when it finishes raining, the water stays in the puddles. The brain is full of potholes. When your loved one has anesthetic surgery, the reason for their decline, not only in the stage of the disease, but especially in their communication abilities, is due to the brain being full of potholes and not able to clear the anesthesia properly. There are changes in perception that occur as the disease occurs, and these are all part of communication. Visually, I don't see things as well. I don't see people as well. Things are moving too quickly past me. The rate and speed that you and I walk, Chris, is much too fast for someone with dementia. With dementia, I have to slow down to 1 step per second to give them a better opportunity to have their brain find me and then see me approaching without me appearing to be as though I'm running towards them and could scare them and cause a startle response. Hearing, they can't track words, sounds, noises. When we set off the fire alarms to check the buildings, our residents usually don't notice it at all, but our staff is covering their ears. People with dementia can still understand your pitch and tone of voice. They can tell if you're making fun of them, if you're laughing at them, or you're laughing with them. Taste and smell, it's the taste and smell of sweet things. Touch, it's important that we continue to touch our people with dementia, that we continue to give their skin tactile sensation, because that's a critical part of human life and human behavior. And humans that don't get touch are more withdrawn, more agitated physically and verbally. And then you have these other 2 perception symptoms, Chris, that you and I were never really taught about. The vestibular and the proprioceptive systems are what allow us to see ourselves in space and time among the things around us. And so one of the first things that family members notice is their loved one begins to bump into things or walk into things. And then the family notices that the person begins to have falls. And the falls are related to this damage to the motor cortex, the limbic system, the premotor cortex, and the basal ganglia, but also damage to the perception ability of being able to see myself in my 7 senses as to where I actually am in relationship to the objects in the space around me. So I may step off a curb and fall onto a parking lot. I may walk into a wall or the doorknob or the side of a table. These are very common things, but they're part of the brain damage that's occurring. And the communication to you is this is not somebody not trying hard enough. This is somebody with brain damage. So vision changes are quite remarkable, and they change how we approach your loved one. In the beginning, there's the loss of peripheral vision. So as you're watching me, just do this and realize that to see around me now, I have to turn my head. So when I look at your loved one, I'm watching to see, do they turn their head when they're talking to someone else? After peripheral comes periscope vision. It's as though they're looking through the periscope on a submarine. And this is all they can see, Chris. They can't see up here, can't see down here, can't see here, and can't see here. And if you do this and look across a table, you realize you can't see your food. And that's why we work so hard to place plates right where the person with dementia can see them, because if we don't, I'm going to stand up and reach over there to get Chris's pie, because why did he get pie? He doesn't need pie. I like pie. I should have the pie. Then it becomes binocular vision. And once it's binocular vision, Chris and I can tell, because now the person twists at the waist to try to see what's going on around them. And then in stage 6 of the disease, some people with dementia will develop what is called occipital blindness, and the right occipital lobe will lose the connection to the left eye. And that means the person only sees through a small tunnel in their right eye. And that means when I approach, I must approach slowly. I must come down to whatever their eye level is, and I must make sure that I am in their eye and that they are looking back at me. And that's my best shot at letting this person know I'm there, and knowing I'm there is part of communication. If I don't do that, I will appear to have suddenly popped out of nowhere. And if I pop out of nowhere, then I've just scared you. So because of these changes, it means that movement is different, and your loved one will even try to communicate that to you. Movement in a wheelchair is 1 step per second. And if the person with dementia, if all they say is slow down, that means slow down. And if they're clutching the side of the wheelchair and they're trying to put their feet down, they're communicating that I'm moving too quickly. I need to slow down. You have to remember, movement changes blood pressure, movement changes heart rate. If I begin to scare them, then I activate fight, flight, fawn, or freeze, and I'm scaring somebody. I don't want to do that. I want to move slowly to help them understand. If I don't do this, we get fight, flight, freeze, or fawn. And Chris, that doesn't change in dementia. If you were a fighter naturally, now you're a fighter with dementia. If you were a freezer naturally, if something frightened you and you just froze, well, you still freeze. It's just, it can take hours to calm you down and bring you back to what your normal feeling is, rather than just a few moments. I had a grandmother, Chris, that used to say, you can get happy in the same clothes you got unhappy in, meaning get over it, move on, let's go. This is just a thing in the past and move forward. But for somebody with dementia, calming down from having their adrenaline set off by me moving too quickly, moving them too quickly, it can take them hours, even 24 hours in sleep before their brain will rebalance itself. So I always approach from the front, and I make sure that I come down and I'm looking in her eyes. And the conversation, Chris, is always where that person is right now, not where I want them to be, but respecting their brain damage and giving them the best shot at a conversation of communication by staying in where they are in their file cabinet. Now, sundowning is a communication that families get alarmed about. And you and I get alarmed about it because it means this person is now looking to wander. And that's why we have secured communities. Your community is set up where they can safely wander in and about, but we lock doors at nights. We don't let people out during snowstorms. We make sure that they're safe to wander. But sundowning is just human habit. Later on today, I will sundown. I will leave here and go someplace else and get food. I will sundown. From the time humans began, we did this behavior. We stopped hunting, we went back to our caves. We stopped farming, we went back to our cabins. In my lifetime, my mother stopped homemaking in the afternoon and got ready for us to come home. We came home in the late afternoon. My father came home in the late afternoon. He left his job and came home. So it's instinct. It's what you and I have done always. And then, Chris, you can understand that each cell of your body holds your DNA blueprint, meaning that literally we could scrape some of your cells and grow a new Chris in a petri dish. We just need a really big petri dish and a lot of time. You understand that, right?
I do.
Can you then understand that each of those same cells also contain your circadian rhythm? And in you and I, our circadian rhythm is running like clockwork. And so our body says it's time to get up. Our body says it's time to go to bed. But people with dementia, their brain is now interpreting circadian rhythms at all different times. And so during parts of the disease, they can stay awake and in movement for 36 hours at a time. Now, the clock here is set to 2 o'clock because 2 o'clock is actually when sundowning begins. If you'll think about it, both at school and in your job, at about 2 o'clock in the afternoon, you start trying to think of how to shut this down for the day. Some of us are very skilled at it. We get everything shut up by 2:15, and then we just look busy until 5 o'clock. And you all know you work with someone who does that. But in dementia people, sundowning may be present from stage 3 forward. For other people, sundowning never happens. For other people, it's a stage 5 or a stage 6 behavior. And food is our great redirector. Popcorn is a wonderful redirector. You've just got to make sure it's not a choking hazard. But food is a redirector, and sundowning is just normal human behavior. The difference is Chris and I actually have a place to go today, whereas the person with dementia is communicating to us this primitive instinct and communicating this need to leave. It's just they no longer need to do those things. Now, these are the brain comparisons, normal to Alzheimer's. And so this is why we don't quiz people with dementia. They have brain damage. We can't communicate with somebody with dementia if we don't allow them the grace and the understanding that the reason they're behaving or not behaving the way that we would like them to is because of brain damage. They don't follow our instructions. It's communication. This is the backward part of the temporal and the occipital lobe. They're not hearing and understanding what it is that we want to do. They slap or yell at us, and that is communication, Chris. It's saying I'm annoyed with you. This is a slice of the frontal lobes. And then this is why, in the end, there is no speech, verbal communication. And it's because those areas of the brain don't exist anymore. It's not them not trying to, it's because they don't exist anymore. Now, Chris, that doesn't mean people don't see miracles. And I've seen miracles, and everything I know about science and medicine tells me this shouldn't happen. But I've seen a woman call her husband's name in her final breath. And everything I know about dementia said she hadn't spoken for 6 months. She certainly shouldn't have known his name, but she did. A lady that I knew in West Texas lives in one of those counties that's bigger than states on the East Coast. And the population of the county is 3, her husband, and the sheriff. And to find placement for her husband, she actually had to go to a skilled facility 4 hours away because that was the closest facility for any kind of care. Throughout their married life, she and her husband, when they parted from each other every day, she would say, I love you, true. And he would answer, your eyes so blue. As she was leaving that evening to drive back to her ranch, she kissed him goodbye. She hugged him goodbye. And she said, I love you, true. And he said, your eyes so blue. And he hadn't spoken in 6 months. So what was the phone call when she got home, do you think, Chris?
She wanted to know what the miracle was.
He was gone. And the miracle was in her final moment with him. He still told her how much he loved her. Now, these are your most common forms of dementia. And each of these dementias may require a little subtlety in your technique or an understanding of what your loved one's going through. So remember, mixed dementia is any type of dementia that's mixed together. So this person may have much more difficulty speaking to you or having communication that has meaning to you because their brain has more than one terminal disease attacking it. I met with 5 families last week in Philadelphia, and all 5 families had a person with multiple forms of dementia, although they had thought the doctor had only said 1. But when you looked at the scans and you looked at the MRI summary reports, the doctor thought that the doctor was clearly saying multiple forms of dementia, and the family didn't get it. So I have to use my knowledge of dementia to help me understand this and how I'm going to communicate with that person. Now, dementias of the Alzheimer's type, they're typically not going to lose that ability to truly respond pretty much to what I'm saying until we get about midway through stage 5. And then midway through stage 5, they're really starting to have trouble understanding all the words I'm using. So instead of a big long run-on sentence with a bunch of clauses that has a bunch of questions in it that I want you to answer for me, Chris, I'm now shortening my sentences to 3 or 4 words. And I'm constantly watching their eyes to see, did they get all those words, or did they misunderstand that last one? So at the beginning of stage 5, we believe they understand 3 out of 4 words. So I can have a pretty good conversation, Chris, as long as I'm repeating, and understanding this person's not making me do this on purpose. I'm repeating because they have brain damage. But then later on, I'm watching to see if what I'm repeating is making sense. And the whole time I'm doing this, Chris, I know that there is a day coming when they're not going to understand any of those words, because by the end of stage 5, we believe they understand 1 out of 10 words. So they're still going to respond to my pitch and tone of voice. But in Alzheimer's, it's going to be stage 5 where I can have that conversation for the most part, as long as I'm paying attention. I can't just be walking around talking because this person doesn't realize I'm talking to them. I may have moved out of their visual field. They have trouble with hearing. They may not hear the sound and interpret it as anything. Another thing, Chris, is we now realize that people with any form of dementia have tinnitus. And there's a very high probability that in stage 6 of the disease, all of the dementias begin to develop tinnitus. And tinnitus is a ringing in the ears. So now I'm speaking, but now I'm really watching to see, are they responding to the words as though they hear them? Are they responding to the words, or is the tinnitus too much? Is there too much noise going on inside of their hearing mechanism that's not allowing them? And again, remember, it's actual brain damage. And in this particular brain, there is tremendous damage in the frontal lobes where speech is. There is tremendous damage on the left temporal lobe where formal language is. The right temporal lobe's got some holes in it, but I bet you singing and cursing are still working. So it's all brain damage. On the vascular dementias, it's going to be a different presentation than Alzheimer's because the vascular person doesn't lose their hippocampus right away. It's not until much later in the disease. But if I'm having a verbal conversation with this person, again, I'm going to be doing a lot of repeating. I'm going to be expecting Alzheimer's to come join it, which means they can't make new memory. I'm going to use a lot of old memory, and I'm going to be prepared, Chris. The other dementias are moving in a predictable and progressive manner. Vascular dementia can be occurring in all different areas of the brain. So it really depends on which form of vascular dementia the person has, how advanced the dementia is, and how the person's brain has been damaged. If they've had a massive stroke on their left temporal lobe, then they're not going to be able to have language with me. If they've had a massive stroke in this particular brain, there's been massive strokes on both the right and left temporal lobes. This person's not going to be able to communicate with me verbally, but they still understand my pitch and tone of voice. And these are brains with vascular dementia. In Lewy body, remember, one of the communication clues is actually those hallucinations. And I'll tell you, Chris, when I was a social worker back in the day, the first skilled facility that I was the director in, we had a lady who we now know had Lewy bodies. And at the time, all we knew back then, you either had hardening of the arteries or senility, and then we passed that, and hardening of the arteries became vascular dementia, senility became Alzheimer's. But all she had was a diagnosis of dementia. But every single day she saw children playing, and she would get very upset because she also saw rattlesnakes on the floor. Every day a cousin of hers came by and beat her up, and every day she could see the caregivers having sex. And you have to remember, these hallucinations went on for hours. So our biggest communication block with her was we had no antipsychotic for her to have for these hallucinations, but we knew that she was terrified. So we made a bed under her bed for the baby so that she could see that the child had a place to sleep. We actually kept a broom in her room, Chris, and whatever staff member walked down that hallway was to go in that room and hit the floor to get rid of the snakes. Every single day we called the sheriff and reported her cousin for beating her up, and we assured her the sheriff had already arrested him. And then we just told her we were going to have to get rid of those staff members that were having sex everywhere. We did everything we could think of to try to soothe her and calm her because that hallucination behavior was so frightening. They have delusions that are systemized and typically sexual in behavior. And that communication is going to sound like something that you've been listening to on the news mixed in with sex from their caregiver. And so it's whatever news story they're watching. So I have to be aware when I'm talking with somebody with Lewy bodies that, again, hippocampus has not been affected yet. They understand on a greater level that something terrible is going on in their brain, but they're also paranoid and suspicious at a higher level. So we've got to be very careful with medications. And one of the things that you'll hear from a person with Lewy bodies earlier in the disease is, thank you for being honest with me that I have a brain disease. Other forms of dementia, it's not going to do us any good to tell them that. They're not going to recall it because of hippocampus damage. But Lewy body persons, Parkinson's disease persons understand something terrible is happening. So I can still have a conversation. I just, again, got to keep it short, got to keep repeating, got to keep watching to make sure that the words I'm saying are coming through. And Chris, here's one more example of that. I said to the lady, was your mom a nice cook? And the woman thought I had just called her mother a crook. And as you can imagine, that did not go over well.
Yeah, it does make sense.
Okay, and Lewy bodies mutates. It's slightly different from person to person. Frontal temporal dementias, these folks understand something's wrong. They even understand their brain is dying, but because damage is also in the frontal lobes, they don't necessarily care. So behavioral variant and Pick's dementia, these people make you feel very uncomfortable, but you can have a conversation with them. Again, it's just a lot of repetition. And again, they're not really concerned about what you're doing. They don't really care, not because they didn't love you, but because of brain damage. And a lot of times, Chris, when you and I meet behavioral variant or Pick's disease folks, they're divorced because their spouse thought, they don't love me anymore. They don't ever tell me they love me. And the reason they don't tell you they love you is because that piece of the brain is destroyed during the course of this disease. Primary progressive aphasia, semantic variant, logopenic variant, those are the communication disorders, and how your person stops using language tells you which one it is. And so if I know that the reason she's describing the cat as being soft and furry and purrs, that's actually the disease, that brings my stress level down. And if my stress level comes down, that edge comes out of my voice. And if that edge comes out of my voice, it just should be a better day for everybody today. The last ones are the movement disorder FTDs. And this person, again, is able to use language until their cortical basal ganglia, their basal ganglia area are heavily destroyed. And at that point, Alzheimer's has now stepped in. Alzheimer's is considered a first cousin of frontal temporal dementia. And so now the hippocampus dies. And now I have to fall back on repeat, 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 short, 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 and watching to see if there is an understanding of my verbiage and of the way I'm moving around this person. This is a brain with behavioral variant FTD, and there's just horrible damage in it. It is all being done because of brain damage. Parkinson's disease dementia, about 80% of the people with Parkinson's will develop Parkinson's disease dementia. The other 20% die before it becomes dementia. The later in life you develop Parkinson's, the more rapidly it becomes the dementia. This person, as part of the disease, is going to have a muffled, soft voice, but they can still move to music. So, Chris, my communication with this person may be that we dance together. because that is still available. I need to understand that this person cannot see things right in front of them, not because they're trying to annoy me, but they literally cannot see things right in front of them. They're a little paranoid because their world's not making sense. They're having hallucinations, somewhat similar to Lewy bodies, but not as defined, usually more of a dual thing. They're seeing two dogs and there should be only one dog. And then being aware that music is so important in this particular dementia means that, Chris, a lot of my communication with them is going to be musically and through movement. Now, when I say that, Chris, I want to make sure I'm specific. I went into a home one day, and the lady had moved her mother to her home in Texas from Mexico City. And when I came into the home, classical music was playing. And I said, "Oh, does your mom like classical music?" And the daughter said, "Oh, no, she hates it." And I said, "If your mother hates classical music, why are you playing it?" And she said, "Well, the doctor said classical music's good for the brain." Well, not if you hate it. These people have terminal diseases. Make their playlist of the music you know they like. I was driving to the airport, Chris, and there was a radio station that was advertising it. It only played real old country music from the 80s, the 90s, and the 2000s. And I thought how different that was from the previous station that told me they only played real country music because they only played Patsy Cline uh, and Hank Williams. And so it was interesting to me that we have different ideas of what typical music is. You know your loved one best. Put together a playlist for them because music still exists, and that is a communication technique. I mean, you think about how powerful music is. How much is a ticket for Taylor Swift's concert going for? Those are almost free, right, Chris?
I don't. I'm not sure how much they are, but I know that they're not free. They're very expensive.
I know they raffled them off, and they were $80,000 a ticket, and
Oh
they're
gosh.
expensive. Now, Wernicke-Korsakoff, this person's more impulsive, more snatchy, more grabby. Um, they have more trouble with communication because of those impulsive actions. They may find that other people don't want to be around them because they're more impulsive, more snatchy, more grabby. It's going to depend on how long they abused alcohol. There should be an understanding and a translation of language up until about stage 6 of the disease. This person should still be able to have some communication with you, but a lot of times where, Chris, you and I as professionals run into conflicts is because of the alcoholism. There may be a tremendous amount of family dysfunction, and there may not be any family who comes to visit because of what this person did while they were drinking. So this one, hippocampus remains a little bit longer in the disease. This person we're usually going to be able to have a conversation with that somewhat makes sense up until we get into stage 6 of the disease. Huntington's disease, remember this one is inherited. This one, the person loses ability for language at the very, very end. Part of that is because of how the disease moves through the brain. Part of it is because of how aggressive this dementia is. And part of it is because of the person is of such a young age with this dementia. The third form of this dementia is called juvenile Huntington's. So this is passed to the children, and the children can actually have the disease start as infants or as toddlers. CTE, chronic traumatic encephalopathy, one of the forms you'll notice is a communication disorder. So we don't have a lot of research on these guys. So far, a few years ago, we had 1,007 NFL football players who had been autopsied after death. 1,006 of them had advanced CTE. One of the forms is a communication disorder. So we know we're going to just use all of our skill sets. And this can be really, really hard for us because, first of all, this is usually going to be a really big guy. We don't have a lot of college or pro players that are smaller. But communication is going to be one of the challenges of it. And I've seen families really think out of the box. I have seen families continue to toss a football back and forth as a way to communicate with their loved one. I have seen the family dress with a ball cap on and coach's shorts, what we would call coach's shorts, and talk to the person as though they're doing physical activity with them, as though they're back on the football field. So they're using what's left to try to have some communication with the person, and they're using things that that person is very familiar with. People who play at that level, who have that kind of kinetic genius, that they're able to use their body in such a way, they usually started handling balls when they were very, very little children. So they're able to still do things that you might not think about because of the type of dementia that it is. Now, I want to come back around to pain and how important it is for us to understand that pain is very much a communication that is coming from your loved one. They're not being mean. They're not hitting us for no reason. They're not screaming or moaning or yelling for no reason. They're doing these things because of how much they hurt. And that's why all of the tools in your itty bitty dementia book are observational tools, including the pain ad scale, because we can't trust a person who has brain damage and cannot communicate properly to give us the correct answers. And so all of the tools that we use in dementia are observational tools, because otherwise we're not able to truly help this person. So make sure to use your tools. Make sure that you think about communication not as being simply words, but as also being how I move my body, my tone and pitch of voice, how my face looks when I have to get very close to someone. Do I look like I'm smiling, or do I look like I'm yelling at them and I'm fixing to hit them? That I'm aware of fight, flight, freeze, or fawn, and that I want to make sure I move slower and I go slower because this brain is damaged and it's working slower. Does that make sense, Chris?
It does make sense.
Okay, do you think that covers communication?
I think so.
It's a lot more complex than just words, isn't it?
It really is. It really is.
And you know, I think one of the things people don't realize, 90% of our communication, Chris, is done by body language.
Amazing.
And so we get so freaked out that they're losing verbiage, but we have this 90% other thing we can still work with through body language, pitch and tone of voice, making sure I'm in their eyes, moving slower, talking slower, repeat, 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 using music. Those things are communication tools. It's not just words. Okay? Do we have any questions, Chris? No, Tam, you did so well. There are no questions. Thank you. Thank you.
I think there is a couple questions in the.
Yeah. Hi, I just opened up the chat and found a few things.
Okay.
Okay, one of them is when you talked about the effects of anesthesia on the dementia brain, are those permanent or just temporary?
They're typically permanent. Very early in the stages, families will tell us, Jamie, that their mom had surgery and they saw no effect. But then think about in your career, how many people have told you they didn't notice anything was wrong until mom did have surgery. Mm-hmm. So the effects are from stage 4 forward are considered to be permanent. It's usually a decline of half a stage to an entire stage, depending upon how long the anesthesia, that they were under anesthesia.
Okay. We have a lengthy question from Christina. Her father is scheduled to have an in-office Mohs surgery for skin cancer on his chest. They're doing a local anesthetic, and they predict it'll take about 2 hours at most. She's saying that her father has early onset mixed vascular dementia, and he's very congenial. His doctor did order 3 tablets of Xanax in addition to his daily antidepressant to be given the morning of the procedure and to have on hand just in case.
They're trying to use a local. So yay, you've got a good doctor. So they're using something that is not going to be pumped through the brain like it would be if I was having anesthetic surgery. So they're using a local, and then they're using the anxiety medicine to make sure they keep him calm while they take care of the skin cancer. So that's a good physician.
Great. She says, worst case scenario, the procedure might need to be stopped, which in case he would have an open wound that would have to be cauterized the following day. So they're trying to avoid this. It sounds like you
I think with 3 Xanax, they got it covered. Yeah,
okay.
this is a doctor that really does. This is somebody who's already gone to we need a local anesthetic because of this gentleman's condition, not a full blown. It's why you and I've had people in our career that the doctor doesn't want to do a hip surgery. They just want us to keep them in a wheelchair, which, we can't do, but we'll do our best. But it's because the doctor's afraid of the anesthesia. So that doctor is getting everything prepped and lined up.
Wonderful. If you have a question and you want to type it into the chat for Dr. Tam, we'll put it out there for everybody.
Or come to Cincinnati tomorrow. Yeehaw.
Christina, you have your hand up. I'll unmute you if you'd like to speak. Oh, I think maybe I muted you instead.
Or maybe not.
She still thinks she's good.
Okay. Any other questions for Dr. Tam?
Okay, and Jamie, they know they can always call me. My number is 254-216-3668. If I don't answer you the first day, it just means I'm traveling. If I haven't answered you in 2 days, please call me again. Sometimes it might be several days before I get to a point where I can clear calls. But if you have a question, something comes up, you don't understand it, just give me a shout and we'll figure it out.
Isn't that wonderful? What you're so generous to offer that to our families. We have Grace, though, that does have a question in the chat. She was probably typing as we were talking away. She says that her dad gets agitated around mealtime, 4 to 5 p.m. He's usually moving a lot, wants to leave. Any suggestions what they can do to calm him until he is ready for bed, which is usually around 7:30? Sometimes he kicks and cries out during his sleep.
Yeah, he's sundowning. So we want you to say for the next 2 weeks, write down what time the behavior starts and be specific about what the behavior is. And misbehaving is not a description of behavior. So it would be he's agitated, he's ambulatory, he keeps going to the door. Try to write down what's happening, and you want to put down the time, because one of the things the doctor's going to want to know is this medication related? Maybe his body is acclimated to medication that he's already on and it needs to be adjusted, or the doctor needs to see what's going on so that he can prescribe an anxiety medicine. I would also fill out the Hamilton Anxiety Scale and see if you're noticing those behaviors in your father, but you're describing sundowning. And we treat sundowning either by gritting our teeth and getting through it because it's not a big thing, or if it's severe enough that they're highly agitated, then we would talk to the doctor about an anxiety medicine. But getting a behavior log ready for the doctor will help your physician do a better job for you. And doing the Hamilton Anxiety Scale, as well as the Cornell Scale for depression. I would do both of those. I would also do the pain ad, because the first thing I'm going to check, even in sundowning, even though I'm 99% sure this is sundowning, I'm still going to check pain, depression, and anxiety. Write down for the next 2 weeks what time it happens, what he does, and then go back to the doctor with those papers. And they should be able to help you then.
Thanks, Dr. Tam. And if you are looking for those scales, I believe you have links to those on your website, and we can
they're on the website. You can Google them. They're all in the public domain. And if you have your Anthem Itty Bitty book, they're in the back of the book.
That's right. And reach out to your local Anthem and we'll help you get those skills if you're looking for them. We'd be happy to help you with that.
Yeah, these are the tools we use in gerontology and dementia care, and they're all observational because you can't ask a person with brain damage how they feel, right? So we have to rely on you to observe them and tell the doctor what's going on. And remember, you know him best, and the doctor doesn't live with him. So let's give the doctor all the information the doctor needs to properly help your dad.
Would you include in that their toileting habits around that time of the day and into the evening?
Oh, could certainly be that. I mean, that's part of if we were going to do a behavior check on somebody in one of your communities. We would look at toileting. When's the last time they had a bowel movement? Am I watching a UTI begin to happen? What is it specifically that's going on? So it could be sundowning, or it could be I'm looking for a bathroom and I don't know what else to do. So great point, Jamie.
Anyone else have a question before we wrap up this edition of our One Wednesday a Month with Dr. Tam?
Yay, always fun. Thank you guys, and good luck to everybody. Please feel free to reach out to me. You're not bothering me. If you start to bother me, I'll send you a bill, and that'll stop. But put your videos together. Anthem has put them into a nice collection right there, and just start at number 1, go all the way through, and educate yourself as best you can about the disease, and we'll do everything we can to help you get through this. Okay.
And we'll be back on July 10th. You should receive an invitation. July 10th, we'll be talking about those observational tools.
Yes, we'll be doing tools finally. That'll be fun.
All right. Thank you, everyone.